Now I was talking about prosthetic loads. Of course, prosthetics in immediate load has to follow other rules than prosthetics on integrated implants. On integrated implants we can do a lot of mistakes. We will have then maybe broken abutments, broken screws, broken ceramics and all these things which we know every day. But in immediate load procedures, if the load is wrong, we will have loose implants, we have failures. And this is of course something we don't want. So please, it's a very simple picture. Try to remember it. This is what I call the supporting polygon. And the supporting polygon is the polygon which we can draw between the implants. In this case, of course, these are BO implants, but it could also be screw implants. And here are only 4 implants. It could be 5, 6, 7 implants. So all those forces which are imposed onto our prosthetics, if these forces are inside this polygon, more than one implant, in the best case of course all implants are participating in the load transmission, and therefore, this requires of course a stiff construction, a stiff bridge, a bridge which is not flexible at all, so we need a metal frame of a minimum dimension. But this supporting polygon tells us where to put the loads, and this supporting polygon tells us also that we should avoid bringing masticatory contacts into the frontal group, because in most of the cases, due to the atrophy, especially in the upper jaw, the frontal implants are not directly supported by implants, so it's like a free hanging zone. And of course, in these cases when we have not supported forces here in the frontal group, we will get extrusion in the back. So we are intruding the anterior implant and we are extruding the distal implant, and this is a pretty bad situation for those implants. As you may know, for a bone can take a lot of pressure and even grow under pressure and mineralize under pressure. The tensile forces are something which bone does not appreciate. Under tensile forces, bone tends to become osteoporotic, tends to lose mineral content, and tends to fade up. Now, to treat mandibular atrophy, the typical case of treatment would be this. So we put implants in the second molar, in the cannon in the second molar. So in this situation, we already have the supporting polygon. And if we want more implants, if we want to put more implants, of course we can do it. We can fill up for safety and to come to more income. Maybe also, you can always fill this up to 8 implants if you want, but it is not really necessary if the masticatory situation is under control. But this is a 9-year post-operative picture from my former clinic. So the patient was treated with those 4 basal implants, discus implants, and the bridge was placed within a few days, probably 2-3 days after the implant placement, and the situation has remained the same throughout all these years. So it's not, somebody might say that the bone was lost, there's a half a centimeter missing, but we tend to make this very cleanable for the elderly patients, because they cannot really work so well with these brushes. And if the implants are a little bit longer and this tooth arch is a little bit higher up, then the situation is more or less self-cleaning, and we do not depend at all on the compliance and on the cleaning possibilities, on the willingness of cleaning for our patients. And this cleaning point of view is also very often not considered. But look at these two-stage dental implants. Two-stage dental implants, usually they have a rough surface. This rough surface is unique in our profession. All these orthopedic surgeons, traumatologists, they don't have a rough surface, and they do not believe that it is of any advantage. Only we have it. And only in our field we have bacteria. For the orthopedic surgeon, he can put in the rough surface as much as he likes. He will just disinfect it with a little betadine and close it tightly, and that's it. There's going to be no infection. But in our field, the oral field is full of bacteria, and we know this. And the other point is, if somebody comes to us in the age of 45, with almost, I mean, with a profound periodontal disease, with tooth loss, with caries and so on, and we have to take everything out and we have to put implants. I mean, this is not the candidate for two-stage implants because it's a non-cleaner. No, the non-cleaner is non-cleaner, and the smoker is a smoker, and the drinker is a drinker. The people don't change. So they didn't clean the last 40 years, they're not going to clean the next 40 years. I mean, some of them, maybe 5%, they will get the shock by the invoice and they will clean it. But most of our patients, they simply, you cannot shock them, they will continue not cleaning. So I recommend that you quickly forget about the two-stage story and you will only put thin and polished implant into the oral cavity because these devices don't need cleaning at all, actually. Don't need cleaning at all. As long as the tongue has some access on the lingual and the palatal side, and while the patient is talking, the self-cleaning process is underway. As long as you give this situation to the patient, you are on the safe way, and you will see this name periimplantitis, which has not been mentioned in any of my books ever. This topic of periimplantitis, you can simply forget it. Okay, here is another treatment approach. So there are PCS implants combined with BOI implants. In this approach, you see that this picture you can see that the BOI may be placed below the nerve. So if you have no bone above the nerve, you just put the base plate below it. Of course, in this case, you better know exactly where the nerve is and where to do it. The nerve must be on the lingual side of the mandible. Here's a clinical case. I'm sorry for the Russian inscriptions, so forget it, please. So the premolars have to be extracted. Then a vertical slot is made for the triple BOI implant. See these three discs are cutting into the cortical. Then the discs will go through the alveolar, I mean through the extraction socket, and they will reach the lingual cortical. And then we have a multi-cortical engagement. Just to remind you, I mean, if you want to try this tomorrow, you have to put a raspa on the lingual side because you must make sure that these cutting discs are not cutting the sublingual arterial anastomosis because this would create really a heavy bleeding. Okay, so basically this picture I should not show this picture because here you don't see that there will be a raspa at the next stage. Now these implants are then bicortically anchored, so the vestibular cortical, the lingual cortical, and so on. So we fill up. And it doesn't make really a difference if you use those BOI implants or the BCS, as long as you have bicortical contact, so the cortical on the lingual or on the vestibular side, or on the vestibular on the lingual side. These implants are going to be stable, and then they are painted by the bridge.